this is some recent data that our group is presenting here at this ASCO meeting. So as a background, in AML, one of the major breakthroughs has been the development of combinations with venetoclax, specifically 2 combinations. One is with hypomethylating agent, azacitidine or decitabine with venetoclax, and the other is low-dose cytarabine with venetoclax. Both of these were evaluated in 2 phase 2 studies that have been published recently and have actually resulted in the US FDA approval of both combinations about 6 months ago. And both of these showed that in elderly patients with azacitidine or decitabine venetoclax, we could get response rates of about 70 to 75%, with median overall survival 18 to 20 months, which is about 2 to 3 times higher than we were getting with azacitidine or decitabine alone. So this was really major improvement, and even in 3-year follow-up, we were seeing about 45% alive, which in elderly AML has historically been 10 to 15%. So this is really revolutionized the treatment of elderly AML. Same with the low-dose cytarabine venetoclax, which it's a little bit lower, the response rates, but compared to single agent low-dose cytarabine, again about 4 times, 5 times higher. So because of this, we are frequently using them in the frontline setting. One of the nice things about these combinations is that they're mutation agnostic, so we don't exclude people with FLT3 or with IDH or with any mutations. And in the community, physicians love this because they're able to start the treatment right away without having necessarily to wait for all the mutational data if they feel the patient is not a candidate for intensive chemotherapy. Elderly, the HMA or low-dose venetoclax combinations are quite effective.